Hello?
Hello, can you start?
Yeah.
Okay, so good evening to all of you. We'll start our usual session. I think this is the 65th session. Start my share screening. Is my screen visible?
Yes.
Once your voice is breaking, I don't know what are this. Okay. Now we'll go with the, as usually we go with a short case, but in fact today I got two short cases first, then go for the long case. This is a story of a 21-year-old woman. He gave history of tremor of head associated with jerky movements of the right hand for the last 3 years. History of occasional dropping of objects of the hand, 3 years. An episodic forward movement of the trunk and neck for the last 1 year. 24-year-old lady presenting with history of tremor of the head for the last 3 years associated with some jerkiness. History of occasional dropping of the objects of the hand. An episodic forward movement of the trunk and neck for the last 1 year. Let us see the video now. Observed keenly. This is the tremor-like movement she had. I turn the head to the right side. And check whether the movement is increasing or decreasing or not. Not much difference. Ocular movements are all normal. The upper limb very closely. See the jerky movements of the upper limb. There's no finger nose incoordination. So the examination was normal, motor power was normal, reflexes were normal. I think that no lower limb incoordination either. I think it was all normal. It was normal. I'll go to the next one. Look at the stance and it's got the jerky movements, the trunk has well. Trunk and neck. Tandem walking was normal. And toss to right, this is how she's.
വേറെ എന്തെങ്കിലും ആയിരിക്കും. ഇനി ഞാൻ സ്കൂളിലാണ് പഠിക്കുന്നത്. എന്തെങ്കിലും
So, what did you observe and what is your likely diagnosis? Am I audible to you?
Yes, sir.
Yeah, please. Yeah, anyone can voice out. What do they feel?
Myoclonus and dystonic tremors.
Okay. So, dystonia where?
That neck mentions.
Okay. Right. So, what is likely possibility she's having? Diagnostic possibility.
Sir, she has additional primary writing tremor or microdose as well. So something like a dystonic macronic dystonia or primary essential macrones, both are possible.
But in fact, if you observe the writing, what she's having is she's got a writer's cramp, dystonia also. Arm goes into abduction and neck goes into flexion of the writing. It goes on writing. See the arm, the O goes into abduction. So she has got an action dystonia of the right upper limb and neck, in addition to, as you correctly said, multiple micronus and the trunk, neck, and heart. And this particular, what is the nature of the micronus? This is called the lightning micronus, a quick micronus, not a slow micronus. So, in fact, I had shown some time back an exactly similar case. What is that? That is again micronic dystonia. So, this is the genetic test was done. Same mutation, micronic dystonia 11, that's autosomal dominant pathology. Do you remember that some time back I had shown a similar girl with again micronic dystonia?
Yes, sir. Yes.
Yeah, in fact, I don't know. In Kerala, maybe I've seen about 10, 15 cases of micronic dystonia. First time I've shown many cases also. This condition is quite common here. So put her on clonazepam at increasing dosage, remarkably not completely well, relatively well under control with micronus. So any questions? We'll go to the next case.
So can this be the manifestation of a DRD as well? DRD.
The micronus and tremor can be part and parcel of dystonia. So that part is correct. But here the micronus was very dominant. Even without dystonia, micronus is there. See, because when she's holding the upper limb, the jerky movements are coming in between. So that's a dominant thing in this patient. So when you get lightning micronus, the upper limb in the range, and normally to the upper limb, always think of micronic dystonia. Dystonia is prominent, and usually any part can be affected in DRD, but usually the lower limbs are affected first. And they can also micronus as well. Micronus per se is not a different entity as dystonia is concerned. So tremor and micronus go hand in hand with dystonia. But here, micronus is seen even without dystonia. That is why we talk about micronic dystonia. Any other? So shall I go to
Sir, can this be part of a SCA syndrome? SCA can they present in the same macronus?
Yeah, in the case of the Ramsey-Hunt syndrome, the progressive myoclonic ataxia syndromes, you can have ataxia and micronus. That can occur. So also in dentatorubral pallidoluysian atrophy, can all produce ataxia and micronus. But here there is no ataxia. There is in studio the gait was perfectly normal, no lympataxia, and total duration is 3 years. She has only no ataxia, only a micronus was there and dystonia was there.
Okay, sir.
Sir, one doubt, sir.
Yeah, please.
Sir, before genetic testing, was any other test done, sir? Like KF ring and all was ruled out, sir?
That clinically, I saw my examine for KF, but in fact, we are seeing such cases so frequently. I do not do any test, frankly speaking, because what they say is such lightning matter. There's the word they use. Predominantly to the upper limb and neck in this condition. So exactly movement like micronus. The previous patient also showed exactly the same lightning micronus. But of course, you need to rule out other conditions, as we said, Wilson disease, any cause for dystonia. But here, 3 years duration, only micronus and dystonia. So the point which I thought they will do genetic test next.
Oh, okay.
Okay, this is a story of a 60-year-old female He gives involuntary movements of the left shoulder for the last 1.5 years. 2 months later, patient developed involuntary movements in and around the mouth, which later spread to affect both upper and lower limbs and trunk. There is episodic abnormal posturing in the right upper limb in the form of extension of the shoulder while walking. That does not present at that's only while walking, the arm goes into an extended position, posture. There is no history of cognitive decline or behavioral abnormality or psychiatric symptoms. There's no positive family history or any history of drug intake. The drug intake history was repeatedly asked, but it's not there. If you ask the patient to bring all the drugs which he has been receiving, it did not contain any neuroleptic or any radios. Let us see this lady's video. Look at the face and limbs and all. Again, the amazing type of movement, neck movements. She cannot maintain the tongue extended and put it. Also shows some abnormal movements of the tongue mouth. Motor or normal. You can live slowly. The reflexes were normal. Cognition was normal. Memory testing everything was normal. Plantar was downgoing. So, what did you observe? What is your likely diagnosis? Or what are investigations like to rule out? Before think that, you have to keep it daily in your mind so that we can plan investigation accordingly.
So looks like
Choreoathetoid movements.
Pardon?
Choreoathetoid movements.
Yeah, movements of normally chorea and occasionally some dystonic contractions as well. So as I said, choreodystonic movements are predominating. So what could be the etiology? Is affecting the lower facial region, upper limbs, lower limb, is there any community impairment or any weakness?
Family is not.
The family history is not there.
Drugs also not there.
No history of any drug intake. So these are the two common things which I considered first. So specifically, it is not there in this picture.
So, neuroacanthocytosis, Wilson's or Huntington's, as there is no family history, we should actually consider neuroacanthocytosis and Wilson's, because since
Yes,
there is no
family history may not be there all the time. There are some reasons why some of the cases family history may not be there. But even after 3 years, there is no memory loss or a psychiatric disturbance in this patient. Chorea dystonia is that, but still, that's a possibility you have to keep in mind. For Huntington disease like states, some CNI off conditions often put this chorea and memory loss without a strong positive families. Okay, I think we can't say make it most likely some degenerative condition like Huntington's or some other condition which you had in some neuroferritinopathy or some other conditions. NDIA can be kept in mind. Neuroacanthocytosis usually it's actually classically orofacial feeding dystonia, and other features should be seizures or neuropathy or some other thing, but it's purely correlated in a separate movement. Okay, so what investigation you want to do?
MRI brain.
Okay. Before that,
thyroid function test and calcium.
yeah, that's it. So thyroid function was done, that is normal. Calcium was done, and the people have already sent already before it came to me. This was already done, which is negative. Calcium is normal, vitamin D is normal. Thyroid TSH is also normal. So you want MRI? Okay, I'll show the MRI.
Peripheral smear done in this case, sir?
Peripheral smear was not done. But that was not a strong possibility, which has no other features to suspect for the psychosis. Age also is out. She's 60 years old. Okay, this is the T1 weighted sequence. We'll run through all the sequence and finally ask your opinion. T1. This is the T2. This is the player. This is the coronal filter for the caudate vector. Some atrophies there on one side. Not uniform, only one area. This is the diffusion. This is a diffusion again 2000. So, what do you think now? Now you're
Vascular post-stroke. She must have had multiple vascular occlusions.
okay. But the disease is progressive over 3 years.
The MR shows
Later on,
multiple
sir.
infarcts, but I don't think that can explain her present clinical condition. There are infarcts, but I don't know. I think it's not related.
Delayed onset of movement disorders happens.
No, as much said correctly, but usually if it's a gradually progressive illness along the orifice region and all, that is unlike. Usually post-hoc occurs unilaterally. Following an infarct, there is a weakness, and subsequently dystonia and the chorea can develop. Not chorea, dystonia and tremor usually develops later, much later than the infarct, and they can progress also over a period of time. So that's not against. But in this case, I still think that's infarct because of two reasons. One, she has infarct in the both basal ganglia. And suppose this one side is affected, followed by the other over a period of time. It may look like apparently progressive over a long period of time. We do not know at what time the infarct has occurred. Suppose one infarct has occurred 3 years back. So that is what is a delayed development of involuntary movement. Subsequently, another infarct of the contralateral basal ganglia. So probably that is why it becomes bilateral and apparently progressive. No, this is my contention. I am not 100% sure, because that's only way to explain this patient. Since there is no other explanation in this particular patient. And the site of lesion, what that is typical of producing late onset chorea. And that is the posterior part of the putamen. Both in the case, in fact, is in the posterior part of the putamen. So that okay. This is only Virtual Robin spice. This is not an infarct. But this is an infarct. This is another infarct. Again, the posterior putamen. This is the anterior, and here also another infarct is thalamus. So these are the classical sites of producing post-stroke chorea and dystonia.
What can
Yeah, please.
what can be? I mean, like as a treatment part, sir. The usual.
I put the patient on this thing, Revocon, that is tetrabenazine. So
Okay.
with that medication, I do not want to follow up because this patient I see only 1 week back. I think some literature, such literature. See, bilateral basal infarct producing late progressive chorea dystonia. So if you look at the 2-3 key sentences from the literature, movement disorders resulting in baseline infarction typically present unilaterally in the contralateral side of the ischemic lesion. And there is a delay in the onset of these conditions after the stroke occurs. The movement disorders present with various symptoms, including dystonia, chorea, parallelism, and trauma, spontaneously resolve within several years. These are the order of development of this voluntary movement, post movement. Chorea is the most common. Then comes dystonia, then comes other things which I mentioned here. Now, what is the temporal relationship between stroke onset and the movement disorders, acute onset or delayed onset? Parallelism, chorea, myoclonus, Ataxia is primarily developed as an acute manifestation, as you all know. Whereas tremor and dystonia tend to manifest as delayed onset movement disorders after baseline function. The average delay in the onset of dystonia is 9.5 months. It has been described as late as 4 years. It is a relatively long period of time compared with other movement disorders. The sites of lesions in the lymphoma nucleus, globus pallidus, are the most frequently implicated in dystonia, especially those in the putamen. Clear thalamic stroke can also induce dystonia. Posterolateral paramedian syndrome and nuclei are typically involved in dystonia. She also when her hand goes backward while walking. That's actually dystonic conditions I have seen, but I could not record it here. Most patients that have dystonia following baseline thalamic is initially present any place and dystonia later. It's not uncommon for patients present combination of symptoms associated with multiple involuntary movement disorders. Following thalamic stroke, complex movement disorders can present dystonia, athetosis, chorea, and action tremor. Now, this is the physiology of why it is occurring late after the infarct. Okay, any questions?
What are the points against the Wilson's in this case?
Age group is quite old, right? 60-year-old. And only chorea dystonia, that nothing else. But if you're younger age, definitely we should keep that possibility.
MRI wise, MRI only if I'm using MRI.
No, MRI is not fitting with you when Wilson disease at all. Here is only focal infarct which is seen. MRI, what you see the classical hyperdensity in the putamen, basal ganglia, as well as the brain, so-called panda sign and less appearance. Here, that picture is not fitting with. It's really focal infarct, not a diffuse involvement of the basal ganglia. It's even symmetrical affection.
Sir, recently I had a patient who came with acute onset of unilateral postural tremor, and his MR shows a watershed infarct mainly in the front operator occipital region as a linear lesion, mainly cortical, but the subcortical basal ganglia were not affected. And he was treated with a statin and other usual measures. And for follow-up, he's much better. There's no tremor. I didn't give any propranolol or any other clonazepam and all, because the history is so acute. That is the reason, because he came with acute onset of tremor, and the MRI showed this picture. And after treatment, about a month, he improved.
That's one condition called, this lesion was in the cortex, not in the basal ganglia in your patient.
Yes, sir. Yes, sir.
So there's one condition called cortical tremor. That is actually for something like a focal seizure, which mimics like a tremor movement. And again, a similar patient, just like tremor only, rhythmic movements going on, not jerky contraction, which actually a lesion showed a mass lesion in the brain. And the patient had an EEG finding also on that side.
Okay.
It's called cortical tremor.
So this patient had a M1 stenosis also. It's a critical stenosis of the middle cerebral artery, some watershed infarct like. And after this thing, now on follow, he's been under follow-up, and now he has no tremor, and his symptoms were much better. So why I suspected was that his acuteness and the acuteness of the tremor, and he was fully conscious and all. There is everything. I mean, there is no features to suggest a seizure or something in that patient.
And even in acute lesions, so the basal ganglia acute tremor is described, but uncommon. Described. Usually, what they used to do is hemibalismus and hemicoria, they occur acutely. Tremor and dystonia usually occurs late, but there are reports where they can describe acutely also. Why I considered cortical tremor in case there is no lesion in the basal ganglia in this patient? In your patient.
No, I didn't repeat the scan. Probably I don't. I mean, in that particular patient, only the cortex was affected. Cortical and subcortical, the basic ganglia were unaffected. But maybe after some time, if I had repeated the scan,
that's a possibility. Yeah.
Okay, sir.
Okay. Shall we go to the next case?
Sir, treatment part of that, other than Rivocon, which drug would you suggest if Rivocon doesn't suffice?
As you know, the problem in dystonia management and chorea management, the dopamine blockers or dopamine depleters are the best things for chorea and choric movement. It's a hyperdopaminergic state. It's a problem is the indirect pathway. So that's something which we usually give. Rarely some people respond to passive. Even though there is a therapeutic antagonism, they may respond to passive anti-cholinergic test. Levodopa can worsen it.
Haloperidol is very good, sir. Haloperidol.
Dopamine blockers. Dopamine blockers and dopamine depleters. These are the two things which are usually given.
Okay.
This is the dopamine depleter. Except for the dystonia due to, dopa response in dystonia, where it responded dopa or dopa, and some other conditions called dopamine agonist as well. Most of the dystonias do not respond to levodopa. Okay, shall we go to the next case?
Yes, sir.
Okay. This case is from Dr. Chaitra. This story of a 16-year-old boy, very interesting story. 9 days back, When he got up and went to the toilet as usual, and while he was sitting in the toilet, he noticed pins and needle anesthesia on the right lower limb from hip downwards. He had no other problem, no walking difficulty, no pain. He took the shower in cold water and he noticed that he could not feel the coldness on the right lower lip of the mid-chest. When his mother applied warm oil on the right lower lip, he could not feel the hotness on the right lower lip, but could feel the touch, the sensation. So he could not feel the hot and cold on the right lower lip, the mid-chest. There's no walking difficulty, no preceding fever, no persistent neurological symptom. He was admitted in the hospital and investigated. He was administered 5 injections of IVMP, and on the 3rd day, all his senses completely improved. The doctor who treated the patient sent him for the 2nd time. This is the story. At the time when he came to me, he has no complaints. He said, whatever I had improved. So I started examining him. But I found that he had a left hornless. See, right pupil, left pupil is constricted. You can see that the left pupil is small compared to the right.
He has got a horn. See the pupil
Left pupil is smaller.
Left side and right side.
And looking carefully, bringing the eyelid down, he's also got a partial ptosis on the left side. He's got a partial ptosis left side.
Got a partial ptosis.
And that is correctable.
Right and left.
It's correctable. Looking up, it gets corrected. So taking both the thing together, he's got a partial ptosis and a small pip on the left side is quite honest. The rest of the examination is open movements were normal.
പല്ലിയണിച്ച് ഈ ഫാദറിനെ നാക്ക് നീട്ട് ആന്ന് പറഞ്ഞ് മതി ഒന്നുകൂടെ പറഞ്ഞ് മതി അങ്ങനെ ഈ കുത്തുന്നത് വ്യത്യാസമില്ലല്ലോ. ഇതും ഒരേപോലെ
Tone and power was normal in both upper and lower limb.
മുറുക്കി ഒന്ന് പിടിച്ച് കൈ ഒപ്പിക്കും. എൻ്റെ വെള്ളിയൊക്കെ മൂക്കിട്ടുണ്ട് അങ്ങനെ ചെയ്യും. എൻ്റെ വെള്ളിയത്തോടെ മൂക്കിത്തോടെ
There's no incoordination.
മൂക്കിത്തോട്ട് ഞാൻ നേരെ പൊക്കിക്കും. ആദ്യം ഇത് പൊക്കിക്കും. കിട്ടും ആദ്യം
There's no lower limb incoordination. Reflexes were normally elicited. Abdominals were intact. Lower lip was slightly brisk, but can be taken as normal. Because there's no asymmetry by that reason. And plantar was downward.
ഇതും ഒരേപോലെയാണോ?
Since it's equal in both the lower limb,
ഇതും ഇതും
it's
ഒരേപോലെയാണോ?
equal. It's also equal.
ഒരേപോലെ.
When I was asking where was the level he felt, that is the area which is felt. I started taking the finger.
കുത്തി വരുമ്പോൾ എന്തെങ്കിലും വ്യത്യാസം ഉണ്ടെങ്കിൽ പറയാം.
There is no difference anywhere. Initially, he felt that was the thoracic lower margin of the rib cage.
തണുപ്പറിയുന്നില്ല.
He is able to feel the cold
ആ തണുപ്പ് കൂടെ ഉണ്ട്.
equally well on both
ഈ
sides.
വെച്ച തണുപ്പും ഈ വെച്ച തണുപ്പും വ്യത്യാസമുണ്ട്. ഒരേപോലെ. ഇതൊക്കെ ഒരേപോലെ.
Febrile is also normal.
ഇതറിയാമോ? കിരികിരിപ്പ്. ഇത് ഈ വിരലിന്റെ
Joint
താഴെ
is also normal.
എങ്ങനെയാ?
Thrombus is negative. And walking normal. So in fact, except for the harness, everything is improved. Get pain and temperature loss below on the right lower limb up to the mid thoracic region. So this is the finding. So electrons, everything normal now. So where is your localization and what is likely? Probably we can't say straight away. Localization at which we can say. Where is your localization?
Left upper thoracic cord, controlling spinothalamic tract, and the sympathetic fibers.
Okay, left upper thoracic. And what
Sir.
left
Sir,
lateral? Yeah.
In the lateral medullary, left lateral medullary, far lateral medullary.
Left lateral medullary.
Okay. Anything else, anywhere else?
That is the only level, I think.
These are the two what you all said correctly too.
Lateral.
Bindu, you want to say something?
Yes, sir. Left lateral level, lateral medulla, because that can give you rise a pseudo spinal cord kind of.
Yeah, pseudospinal sensory loss. Okay, you have to put it. But the first possibility is also equally strong. No, we can't totally rule out that possibility. But more commonly seen in that level. Okay. Now, what do you want to do now? MRI, no? So in the MRI brain, only few cuts are available. I did not show any lesion in the middle.
You have to get finer cuts, sir.
Okay, you want to repeat MRI now. But before doing a repeat MRI, you have to ask the patient, you already come with an MRI, you go another MRI. It will be frowning at you why this doctor is asking again. So you have to be a little more certain about the localization, correct? I want to be certain about the localization. So what clinical test will you do?
Corneal reflex.
SSC, sir.
Corneal reflex is one which is normal.
Lateral pulsion. Lateral pulsion.
Yeah, so lateral pulsion. So I look for lateral pulsion. So look for lateral pulsion.
ഈ കണ്ണടച്ചേ അടച്ചുകൊണ്ടിരിക്കേ തുറക്കരുതേ അടച്ചുകൊണ്ടിരിക്കേ ഇനി കണ്ണു തുറന്നേ അടച്ച മുറുക്കി
So lateral pulsion.
ഇനി വിട്ടേ കണ്ണു തുറക്ക.
So there is no clue to suggest a medullary involvement. So what do you want to do now? Again, in terms of medulla.
Sir, can we do a sneeze reflex as well as a gag reflex? Would that do any good in this case?
I did not do, but more doubtful, no, because lateral movement is normal. Only reflex loss due to medullary lesion. Technically, you are right. But yes, I don't know who spoke first. See, sympathetic fibers descend from the cervical cord down up to the D1, D2 level. Lesion can be anywhere to that level. Got the point? See, need not necessarily be lateral. We usually see lateral medulla, but also you have to keep that possibility in mind. So, what do you want me to do?
MRI of the spine, sir. Thoracic spine. Cervical.
Cervical and thoracic. So, this is cervical cord and upper thoracic cord. This is the thing we have to do. So, MRI was there. This MRI, the cervical spine, which will be more potential. This is the C7 area. It shows hyperdensity in the C7 to this is vertebra that corresponds to D1 vertebra to D2 vertebra. C7 vertebra and D1 vertebra corresponding to C7 CA D1 segment. This hyperdensity in the cord. To the axial cut, again more common on the left side, corroborating with the right spinothalamic sensory loss. Hyperdensity is more towards the right. Okay, make it more very clearly here. Okay. Now, what is causing is that Horner syndrome, as already told, is least on the sympathetic center at D1. from this mesometric tract. Now, what is your diagnosis now? You found an MRI lesion in the thoracic column, let's say. Proved with
Lesion, sir.
pardon? Pardon?
Considering the fact that it responded fast to steroid,
Yeah.
so demyelinating lesion would be the first possibility.
Okay.
This new nucleus pulpus and embolus also equally straight because he must have strained and
But that's not history like that. Yeah, that's what the story is very. He got up as usual in the toilet. While sitting in the toilet, he noticed there's no straining, nothing. No pain, nothing he had. Some paresthesia, then he took the bath, then only noticed he's not able to get the cold sensation. It is not favoring a nucleus pulpus.
okay.
So, what do you want me to do now?
CSF still?
Yes.
Okay, so can be what do you think is MS, NMO, MOG or ATM? What do you think? What likely?
NMO, sir.
Isolated demyelination, sir.
It's confined only to left half of the cord. Usually NMO is usually centrally located. Okay, moreover, it should span more than 3 segments. It's less than 2-3 segments. Cylindrol should favor a MS or ATM. That's just one it is like, but partially ATM. Okay, so you want CSF to be done. But you want VAP also to find out any other sites affected.
Yes, sir.
Yes, sir.
Any first lesion. So these are the things which are required, no? Okay. So it's a routine blood count. I think it's normal. I can skip that. VAP was done, which is normal. Then CSF was done. There's no band. No, what do you call a band? NMO antibody was negative. Then CSF sent for Microbacterium to that's also negative. So what else you want?
Vasculitic profile.
Okay. So ANA profile, that's done negative.
E sir, transesophageal echo.
For what? You
Yeah.
embolism is very unlikely, no? It's only
Okay, sir. Okay, right.
sulcocapital artery also. There's no pyramidal weakness. Only spinothalamic tract is affected.
So in this case, there was a pins and needles initially. So
Same time. Yeah. The same time.
No, sir. That pins and needle is it part of a posterior column or a spinothalamic?
That can occur in both. That can occur because even spinothalamic tract means antispinothalamic contains pain fibers, test fibers also. So that's not against.
Okay.
MRI brain, sir.
MRI brain was initially showed, no? That is normal. The first thing was in MRI brain. So what we to do now? Send the patient with the diagnosis of demyelination or do something else.
COVID test, contrast MRI.
Very good. So,
Adam, sir.
yes, so MRI with contrast. This is the MRI with contrast. This is the contrast enhancing lesion here. Okay. Rest all hyperdensity was only edema. That's a lesion there. Okay, you can find out this is enlarged, zoomed up view of that particular contrast enhancement. I'll show some more picture. Okay, this is the plane. This is the contrast. Again, this is the contrast seen on the periphery of the cord like this. Habitually enhancing lesion seen. So what is your diagnosis now?
Could be tuberculosis, sir.
Yeah. So the possibility now is still we can't rule out a demyelination, but we have to keep other possibilities. Okay. How often, if you look very carefully, see there's a central hypointensity surrounding by hyperdensity. Can you make out that thing? I don't know whether you can make it out. Periphery is more enhancing than the central part, as you see usually in a granuloma-like thing. But this can occur in demyelination. But usually in MS cerebral lesion, this is seen, spinal lesion that not commonly seen. But that does not rule out the possibility of a demyelination.
Is it the bullseye signs or something like that?
Bullseye central part is, this is central part is hypo, or less enhancing than the peripheral part. A ring enhancement, more like a ring enhancement. Like if you go by the first PDF, when you zoom up, the resolution comes down. That's a problem. See here, here can you make out the central hypointensity here in this picture?
Yes, sir.
Yeah, rather than when it's zoomed up, the resolution becomes poor, so you can't clearly make out the central hypo. So I can't rule out a possibility of tuberculoma or a sarcoid. So what do you want me to do now?
AC level.
Okay. So CSF, before the manual was done, it was strongly positive 20 millimeter, but CSF ACA level was less than 5. Now what do you want me to do?
So what the X-ray chest and the CSF was normal? CSF normal.
CSF, initially we did CSF PCR was negative, ACA level was also negative. And CSF ACA level is negative, ADA was also negative.
X-ray chest normal in this case, sir?
X-ray chest is normal, CT was not. So what do you want me to do? Yes, improve totally.
We'll keep him under follow-up, sir. A repeat scan after 3 months and.
Okay. So the problem is they're not sure now. So what will you do? Go back and ask the history of tuberculosis or in this past. In fact, at the age of 6 years, he was treated for tuberculosis pneumonitis. This is when he was 6 years old, OPD. When he was 6 years old, he had multiple glands in this thing. He took treatment for 1 year and everything subsided. And it's at the age of 6 years. Now he is 15. So what do you want to do with this patient now?
Trial of ATTs.
ATT? But what is the evidence that he has tuberculosis infection now?
MRI is the evidence. MRI is showing still the lesion. Improvement is there, but MRI is showing still the lesion.
Yeah, the MRI was taken prior to the treatment, but it's correct. But suppose I argue that why not a demyelinating lesion?
Sir, so much of edema around the lesion is out for demyelination, sir.
Yeah, that's one point, right? So much of edema is there. So personally, I think it's more like a tuberculoma because of one, in demyelinating lesion, they do not improve rapidly in 3 days time. How often you do see demyelinating lesions, spinal cord? So many cases you are seeing. They improve over a period of time, but not immediately within 3 days. Such improvement is often indicate edema surrounding the substance of the edema. So there's one relative point, not absolute point. Second point is that the lesion is more edematous gross. And again, not totally against, but more likely to be a mass lesion. But are we justified in putting the patient ATT or will be absolutely certain? He is improved now. He says, I'm all right now. Why should you want me to take antidiabetes? So what will you do now to be absolutely certain?
CSF or CT.
Just a CT chest you can take. Chest X-ray is normal. So what the plan is, you have to do repeat the MRI after 6 weeks. Okay. If still enhancement is persisting, you have to put the patient into tuberculosis or the symptoms worsen again. If they remain like that, again you should start ATT if the enhancement is because demyelinating lesion will remain enhancement only after 6 weeks. And as you know, tuberculosis means continued to remain enhanced, maximum 2 months. persisting, start immunizing. Then you are on the sure grounds. Now for that, some finding little more literature support. MS patients are often small, at least 3 millimeters, covering less than 2 vertebral segments and usually less than half of the cord area. Actually, images, most lesions are located in the, but I saw now patients, mainly in the lateral and dorsal column, and also white man. The focal lesions strictly contain diameter and usually MS. This I will skip. Active MS lesions of spinal cord enhance less frequently than brain lesions. Here was vivid enhancement. When enhancement is present, it is typically short-lived, 2 to 8 weeks, although typically less than 4 weeks. And nodular, while ring enhancement is less common. Focal spinal cord swelling is frequently observed in the acute phase. This is from the literature. So this is the story of the patient. So ideally, what I suggested was that to follow up the patient to get repeat MRI after 6 weeks. If the lesion is totally cleared, do nothing and follow up. The lesion is persisting, enhancing lesion is there, start the patient. So this case is also got a management problem. That's why I brought the case.
Is it possible to have a PCR positivity in this CSF?
CSF PCR was negative.
Negative, yeah.
And I initially told, no, initially in the first one, CSF TB PCR was negative. TB PCR is absolutely not very useful, very low sensitivity. Sensitivity has been reported to vary from 30% to 70% depending upon the lab and the type of the kit which you use.
So how common is the myelitis due to varicella, sir?
How varicella producing myelitis?
Yes, sir.
Yeah, that's very common. Very common. But they usually have got associated radicular symptoms and pain, etc. will be there and the site of lesion. They involve the dorsal root ganglia and then subsequently go on to involve the myelitis. Because the virus is reactivated in the ganglion, then go proximally to involve the spinal cord. Okay, any other questions?
Sir, whether some tumors in the primary tumors in the intramedullary tumors, is it one differential, sir, in this patient?
Yeah, could be tumor possibility totally can't be ruled out. Absolutely, you are right, but a tumor usually is not the picture. It's only small ring enhancing lesion compared to the one half the cord like that. I suppose you can argue it's the beginning of a tumor, yes. The picture is not like more like a granuloma as a possibility.
Okay, sir.
But nobody can absolutely be certain whether it's a granuloma tumor, but the past history of a tuberculous lymphadenitis, if at all that lesion is like more like in sarcoid is a possible. Usually sarcoid is just adjoining the pile surface via the subpile involvement is classical of sarcoid. And they can go actually into the cord like a trident sign, but a lesion contained inside the cord like that is just likely to be a sarcoid. Okay.
So, sir, just like the brain tuberculoma, can we, classify the spinal cord tuberculoma in that way? Like I saw, depending on the density, in this case at least, can we apply spinal and as well as the brain lesions?
Yeah, that should be definitely you can apply that. Whatever it is, depending upon whether it is solid tuberculoma, age-shaping, tuberculoma or patiating with abscess formation, the MRI findings will change. In the central hypodensity appearing means it is breaking down into abscess like that. That is the tendency. In tuberculoma in T2, in the case of caseating one, it will be hypo. Here it is not hypo, it is uniformly hypo.
Sir, in this case, MRS would do any difference in this case? Spectroscopy.
Spectroscopy in that area, it will be too small an area. No, I don't know. Why should have thought, I didn't think about that possibility. It's, I should ask the radiologist whether it's feasible in that small location. I do not know where you an MRS in the spinal cord. Okay, shall we go to the next case?
Yes, sir.
Last case today. This again, courtesy of Dr. Balakrishnan from PhD, Coimbatore. He referred this case. This is a story of a 23-year-old man. It's a long story. His complaint started in 2015. That is about 6 years back. Has pain in both upper and lower limb, mainly in the distal parts, and weakness in the form of difficulty in writing, difficulty in making bowls of food with the right hand, climbing stairs, and loosening of the surface of walking. Still, he had pain and weakness in both upper and lower limb, normally distal, but possibly also because got difficulty in climbing stairs. His weakness progressed to the maximum disability in 1 week, needing the support for walking, and has to be fed by another person. And he was treated by a local doctor there. His symptoms remained static for the next 2 years. Even though it did not improve, did not consult any other doctor. Then in 2017, that is about 2 years later, when the pain and weakness worsened, he consulted another doctor who put him on steroids. And his symptoms improved partially, not totally. 3 months later, his symptoms worsened again. He subsequently improved without changing the dose of steroid. He continued with steroid, but his worsened again, improved subsequently spontaneously without altering the dose of steroid. And this condition remained static for the next 1 year, without much improvement or worsening. His pain and weakness did not improve much. So he was considered another doctor and was given injection Tuximab, which did not produce any improvement. He was then switched on to mycophenolate, and his symptoms improved partially, but never totally. Subsequently, that now 3 months back, his weakness worsened again. The dose of mycophenolate was increased to 1 gram twice daily, along with Visalon 30 milligram p. He improved and again worsened again for the last 3 days. He improved till 3 days back when he got transient worsening for the 3 days and he was referred over. So this is a story, long story. So in fact, he had presented 5 years back. So in 6 years back, as weakness of upper and lower limb, normally distal pain, remained like that, again worsened, with steroid it improved partially. While on steroid, again worsened, was even tried in Tuximab, did not produce improvement. So we turned to mycophenolate, that produced improvement. Again worsened, dose of was increased 1 gram BD. Remained like that, again worsened for 3 days, and just while on 1 gram. This is the story. On examination, he is now got ocular nerves are normal. There's no facial weakness. Because impressed with the steroid. Power was normal.
பிடிச்சிருங்க கை மடக்குங்க இது மடக்குங்க பிடிங்க நூற்று வைங்க
Systems are all normal. Lower limb tone are normal. Knee extension normal. Hip abduction normal. And all muscles are normal except the EHL which was weak. Let us check the weak on the right side. Mild weakness on the left side as well. More weak on the right side. 100% is normal. Reflexes are all absent in the upper limb. Numbers were intact. Knee jacks are very elicited. Knee jacks are normal. Our ankle jacks are absent. Plantar flexor. Which is normal throughout the body. All sensations are in fact normal. There is no distal loss of pain sensation. It says equal. Vibration sense is normal. Stable to again normal. The AP is normal in the upper and lower limb. Is it correct? See the gate, thrombus is fine. Gate is over normal. He can walk on heel and walk on toes. So examining scalar is normal. Motor tone normal upper limb. Power is normal. Feet are all absent except both knee jacks, which are very elicitable. Under flexor bilaterally, sensations normal. Converse is mildly positive. Gait no. So, what do you think about the likely diagnosis in this patient?
Pure LML lesion, sir. Possible first is the nerve, second is the muscle, sir.
You think muscle disease in this patient? Normally still all professors are absent. Except the knee.
The first possibility
Sir,
is
LM.
sir.
It's a possibility of polyradiculopathy, CIDP kind of.
Yeah, lapse. CADP is the one which lapses like that. CADP, lapse and CADP. Lapsing initially called lapsing polyneuritis. Okay.
Or CES, IMPS also, there is a motosensory polyradiculopathy also.
What is this? That's also a possibility. And because the people didn't work, right? Yes.
poems to be ruled out, sir, because of the relapsing remitting.
Okay, poems to be considered. Agree. Let us see. The story is, in fact, I taken the previous case record from each admission. So the first admission was 2016, but they thought it's a CADP. So in that case history that I underlined by a red line, I noticed a subacute onset of weakness of front volume. But now is no finding except for the weakness of pH. Because of pain not able to do ADL since January 2016. That's 9 months duration. Neck pain for 1 month. And weakness of, on examination, weakness of muscles more distally than proximally. Upperly more weaker than lowerly. Difficult to get up from squatting, difficult to advance the case, not able to hold its efforts. So this is the findings at that time. Here this thought is wasting of the hand muscles. Power was 4/5. Jerks retained. Hand flexor. Bit normal. So clinical impression was CADP. I don't know why they thought CADP because the jerks are all retained at that time. They did vitamin B12, which was normal. NCS showed motor sensitive polyradicular neuropathy predominantly involving overly demyelinating and axonal. And he was put on steroid. Then the second admission was in 2019. Again, they thought CADP, and this is NCS finding in that time. It showed you can make out the prolonged distal latency for the right median, left median, right ulnar, left ulnar, and the velocity part, the amplitude is okay, except one decrease amplitude of 4.3. And the velocity is right ulnar is decreased. Thus the borderline. This FA was prolonged in both upper limb. No sensory potential is picked up at that time. This is sensory in the upper limb. They will speak all these things. So they said the report was that there is electrophysiological evidence of severe sensory motor demyelinating with secondary axonal neuropathy to be coded. They did ultrasound of the nerve by log H. Is better than that. So I don't know how to interpret all these things. So the impression was there was diffuse increase in the cross-sectional area of all scan nerves, normally in the mid-arm with enlargement of the brachial plexus. The fascicular architecture is showing increased echogenicity without an increased color flow in the nerve segments. Sonographic pictures suggest you even of the probable CA. That is the report. Then in HIV screening, HCV, SPS AG, they're all non-reactive. CD19 cell count was okay. Then in CSF protein was 21, glucose 73, and CSF ADA level is 0.2. Then MRI of the spine, which was normal. This is the cervical spine. So third admission was December 2020. Here they did the CPK, which is normal, PSH is normal. Then ganglioside antibodies were sent, so all negative. GM1, GM2, GM3, etc. The ANA profile only positive as PM SCL. I think that is positive. All other was negative. Then the other test which I done was microbacterium gene test, just sent that is negative. CSF culture and gene expert for tuberculosis was negative. HRCT of the lungs was done, which is no radioactive evidence of active lung infections. I repeated the MRI, that is last year. Again, the cervical spine was normal. This area they thought is abnormal, this hypertensity in the corners. This is the axial cut. In the contrast film, this is a contrast. There is no clear-cut enhancement anywhere. probably they did it to rule out CA, SMBS, SMBS. So this is the impression they said, which I colored with drawn with the line. You'll be find non-enhancing area of T2 hyphenation in one of the corners and prime terminate, which I don't think is correct because this is quite normal. This normally the hyphenicity is same there. That's what I know. So CSF OCB was done because probably in this hyphenicity in that cord. It is negative, NMO, MOG, and other negative. So these are the investigations, the previous submission. So what is the analysis? They came with all investigations. So we get that in mind, what is the analysis?
So no biopsy is not done so far.
No biopsy, I forgot to show the not copy. No biopsy was done from the ligaments that showed axonal changes, no demyelination.
Any dysmorphic features or any deformities of no deformities?
No deformities.
No,
Any
family,
skin
no
lesions?
family
Skin lesions?
No family history. No, it's
Electrophoresis.
electrophoresis. I don't know. I don't know. From the case record, I don't know whether it was done or not. I copied all the records from there and then this was not done. Probably it is not done.
Can this be CMT, sir? Is it?
So let's first think about each possibility one by one. Okay, let us see how many of you will think it's a CAD.
Since there is no response to this medication, it's very unlikely to be a CAD.
They respond. They responded to present is all right now, except for the mild weakness of the EHL. Otherwise, is walking everything normal. They still record support for walking. Are you doing everything? It's definitely improved.
CADP is possible, sir. CADP is possible.
No, I think CADP is not at all possible because I'll tell you the reason.
Sir, knee-jerk is present, you said, Allah?
Yeah, knee-jerk is well preserved. Apart from that point, C is later on. Then CSF is normal. And there's absolutely no sensory finding.
We
So
have to rule out porphyria.
Yeah, okay, porphyria.
He was taking some alternate medicine, Siddha or something. So lead poisoning and everything.
Siddha, he took some, was taking Siddha medications. But it was relapsing. He stopped after that again, it was relapsing and remitting. And it showed axonal changes, not demyelination. So what would you like to do? So I did some other tests again. It's a routine test only. So I wanted to rule out a vasculitis. So the ANA was in immunofluorescence was done, that was negative. And Cienga, Pienga, which was not done earlier, it's also repeated. Was done again, that is negative. So I did a conduction to find out if it's really demyelinating or not. See the findings now? Yes, decreased amplitude. Pardon? All antibodies were negative.
HPSAG.
Negative.
Anti-HCV antibodies.
All is done. That I showed earlier. SCV, SCV, HIV are all negative. That I showed.
So the snap in the upper limbs negative, I mean normal or like
Snap was absent. So you see the amplitude of the NCV now. Decreased amplitude of the amplitude is decreased. Right, sorry, right peroneally, left peroneally decreased, right peroneally decreased, left tibially is decreased, right tibially is normal. And look at the velocity, quite normal velocity. Distance normal, and velocity is normal, and his amplitude is decreased, mean decreased. And in the upper limb, there is no normal. And all sensory potentials are also absent. And only those with the FAV is absent and those with decreased amplitude.
So upper limb median nerve is showing demyelination also.
Upper limb? Which one? Showing there is a decreased seam amplitude with a normal contraction velocity. This is a pure axonal type, as shown by the biopsy as well.
The median nerve, sir, FA is prolonged and latency is prolonged also.
Median nerve, which is prolonged? 5.8, you mean?
Latency and FA also, sir.
Yeah, that's prolonged. That's correct. This is prolonged, but that alone need not take into account because this latency is also a little more longer than the other one. And his velocity is also a little more on the lower side. So in the upper limb, you can say some kind of an early limb. We are not to call CADP. There is a criteria. This is not the criteria. There should be more than 20% decrease should be there. That will be less than 40, less than 30% should be there. So this is not fitted. There is mild degree of demyelination, but not sufficient enough to call a CAD.
And the FA, sir, of the median nerve, it is 35.
Yeah, but the problem is to call it definite prolongation of FAV is more than 31. And it is here the distal latency is prolonged, contraction velocity also prolonged. That also can prolong the FAV latency. That alone does not mean a proximal problem.
Sir, is there any history of allergic disease and history of Siddha intake?
There is one, initially there was history of Siddha intake.
No upper respiratory symptoms.
No upper respiratory symptoms. So in fact, no. What will you? What reply will you give to the referring doctor in this patient? If you get less labs in CADP from various places, what opinion will you give?
It is a vasculitis kind of thing, sir, because it's an axonal.
And that's exactly what I'm trying to say. In fact, if you look very carefully, the picture is the lower limb also. 3 nerves are affected, one is paired, not quickly in a symmetrical distribution. So it's something like a pigmonoris multiplex pattern. Is one some antibody was positive, that is that ACL something antibody, I don't know what is that thing. And it's clearly axonopathy. It's not a demyelinating lesion. No feature suggestive of CADP. CSF protein is not elevated. C is not suggestive of a demyelinating, pure demyelinating. And the clinical picture of is also lately odd because the preserved knee jet. And this antibody is also positive. So probably what I think is most likely a vasculitic neuropathy in this patient, responsive to steroid. Most likely a primary, not a systemic vasculitis, a non-systemic primary vasculitis of the peripheral nervous system. That is what I have in mind. I'm not 100% certain because for want of a better diagnosis, one thing is sure, there's likely to be a CAD. Lapsing CADP invariably will have elevated protein, cross convection abnormalities, thickened nerves, everything will be there, lapsing polychloritis of CAD.
So is it possible that the treatment would have modified the nerve condition parameters?
That's a possibility. Another possibility is that because initially it showed some demyelinating changes, but the problem is that it's all depends upon who does the study. Because unless the technician is doing it properly, because in the previous 2 NCV done also showing different findings. One was showing demyelination, one was showing some changes. So I don't know how far that is there, we don't know. But what is the other evidence of CAD? CSF protein is normal.
Knee jerk also should be absent, no, sir?
Usually. It's well, it's absent. It's well elicited here.
So in whether it's on CASMP, CAAN or CADP, the CSF should be abnormal, isn't it, sir?
Yeah, it should be elevated. Here the nerve biopsy showed axonal changes. I don't know, I missed, I did not put it here. That was done in immense. From the Coimbatore, they said the nerve biopsy in immense. The immense report was axonal. They clearly written no evidence of demyelination.
Sir, how much importance we should give to the CSF protein, sir? Because the patient has improved. He doesn't have any weakness except for the sluggish reflexes, and only NCVS is showing the abnormality, no, sir?
Yeah, you think, but what are the evidences? Since one of the thing is protein. What are the other evidences CADP here at the present time?
But he is under treatment now, so that can affect the protein level in the CSF.
No, I don't know whether it will, every parameter will revert back to normal, except for the amplitude, which is grossly decreased. And why should amplitude also return back to normal? See, demyelinating, CADP is primarily demyelination. Why should the amplitude become decreased with normal conditions? That's clearly not suggestive of CADP. If it is recovered, amplitude should also come back.
Should we say axonal demyelination, sir, clinically, sir? Because the power is normal and reflexes are sluggish in the upper limbs.
Yeah.
That can we say as axonal demyelination clinically, sir?
Clinically, there is demyelination. There is demyelination. So problem is that almost most of the axonal changes, they can have secondary demyelinating changes.
So in this case, the patient presents with pain. So I think the pain must have some bearing on the diagnosis. Like
initially also he had a severe pain, the distal part. That's a little tricky. Let's say everyone made a diagnosis CADP. What I'm thinking differently, because there is no point now to diagnose CADP. Only amplitude decreased with even the treatment, the other thing should come back. No? Avoided amplitude does not come back.
Sir, can it be something like a HMS and where there's worsening due to some tox because he took the Siddha medicines and all? Because if it was a modern neuritis multiplex due to vasculitis, the patient does not have much of a deficit, even though his sensory is completely absent and he has significant.
So he has improved, no? He has been taking this steroid for long, I remember for long, many years. This is improved. That's only possibility I'm thinking. I'm 100% not certain. What else can you think? Unlikely for the hereditary disease. Hereditary disease.
With the episodes of worsening due to some the Siddha medicine.
Because see, if you look at that in HSM and all, one of the key feature conduction is that they're symmetrical. Except for rare variety of 2-3 things, they're quite shows conduction block, the CMDX and all. But all will be symmetrical, uniform slowing will be there in the conduction. That's what the pattern.
Yeah. The only problem with vasculitis is even usually vasculitis patients know if they have this much of nerve conduction abnormalities, the clinical examination should show something. But here he looks perfectly fine.
No, that is not, see, whatever be the disease you think, whether it's vasculitis or whatever it is, the conduction may lag behind. The conduction may not pick up. So, say, for example, your ordinary GBS, external GBS, they improve remarkably well. Amplitude may be low. It's not corroborate with the severe finding to not go hand in hand with the clinical. Severe since in ADP totally recovered, but conduction remaining low.
Okay, thank you.
So I'm thinking that, so one thing is very unlikely to be CADP because of what is the criteria to diagnose? Criteria, nerve conduct criteria does not fit in with, the nerve tissue does not fit in with, there is no enhancement to the roots, there is no thickening such as relapsing bone neuropathy, Caesar protein is normal. What is the criteria by which you can diagnose CADP? Only because of the history and the pain and the onset, as Sumar was telling. That's also a very strong point. Every time we had worsening, he had pain.
Sir, porphyria was ruled out, sir.
Porphyria, I do not know, frankly speaking. I didn't do that. The previous record also, I didn't know that it was done.
The first NCS is suggestive demyelination, no, sir.
Initially, first one.
Yeah, that was sensitive demands. Perfectly, that is just more demands. That is a bit tricky here.
Sir, is it possible this to have a multifocal acquired motor axonopathy? Something like, I mean, there's no conduction block.
That's an axonal problem, no?
Yeah.
The question asked was why the initial conduction was showing demands. That's difficult for me to explain. I can't explain with that vasculitis. Initial picture was not like a vasculitic picture, easily. That's only point was that how far reliable is the conduction studies. At the same time, they did another institute within a few months that showed actual changes, not demanded. So which to believe? So you have to go for other parameters. But for me now, this last NC was done here. If that had showed demandation, I would have definitely voted for a CAD. But we are doing in our own hand, they can monitor it. Okay, anyway, it's a tricky case.
Yes, sir.
Yeah. So
was nerve biopsy was done, sir?
Nerve biopsy showed axonal changes. They did clearly say no evidence of demandation. That biopsy, I don't know where did it go, I don't know.
But it should know vasculitic changes. It should show if it is vasculitis.
No, they did not say, they don't know written any vasculitic changes as well. They are not written it, but depends upon the site where the biopsy was taken. They should show vasculitic changes. Yeah.
They say vasculitis being patchy need not always be showing definite tissue biopsy.
Biopsy, yeah.
Vasculitis.
Anyway, this
So suppose there is a distal conduction block, distal to the point of stimulation. Can we say it's not possible in this case?
That's if you got it, that means all nerves showing distal conduction block. Very odd, no? Every nerve is showing that thing.
Okay.
Usually in that situation, whether some proximal movement, the velocity will also come down. Temperature velocity also come down. Distal latency should also be prolonged. Unless a complete conduction block uniformly affecting, you can't have that finding. Distal latency is without prolongation, you get a decreased amplitude. Always think axonal involvement. You got the point. If you think a conduction block affecting distal to the distal point of stimulation, that block should be uniformly affecting all the nerves, or whichever nerve is affected. If some patchy affection is there, again the distal latency will be blocked.
In that case, we should have weakness also. If there is.
What weakness?
If there is a distal to the stimulation, there is a conduction block, then there should be corroborative weakness also.
Yeah, that should be there. Yeah. That again depends upon how far is the block. If there's only partial conduction block, then you not have any weakness.
Okay, sir.
Sir, in this case, there is no wasting of the limbs. So if it's a axonal, then we would expect some wasting and.
Yeah, in fact, here hand muscle showed wasting. The distal part, I am not sure because I did not pick out any wasting. This was wasting in this patient, as I said currently, no cross wasting. There is some, it's a tricky case. Some points are favoring axonal, some points not favoring axonal. But no definite point there to a CADP, even in the first investigation. They even CS have done the before now. Okay, shall we close here?
Sir, one doubt, sir. Why then the patient is not responding? He is not off treatment at any time. So vasculitis also the same, steroids, mycophenolate, mofetil.
In fact, he did not respond to rituximab, he responded to mycophenolate mofetil. Now he's now. See, on examination is all right, except for the HLV. After hiking up to 1 gram BD is all right.
Yes, yes. Okay.
Okay, then.
Okay, sir. Thank you. Thank you very much, sir.
Thank you.
Thank you, sir.
Okay. Good night. Good night.
Thank you.
Thanks, sir.
Right.
Thank you. Babu.